I have the great honor of introducing my friend and colleague, Dr. Shari Bolen. She's an associate professor of medicine at Case Western Reserve University in Metro Health, and she's the co-principal investigator for the Ohio Cardiovascular and Diabetes Health Collaborative, known as Cardio. Dr. Bolen.
Great. Thank you, Donald, for that warm introduction. And I'm very enthusiastic and excited to be here today to talk with all of you about our statewide collaborative. I don't know if I'm just going to say next slide and hopefully the magic will happen. Great. Thank you. So today I'm going to discuss cardiovascular health in Ohio briefly. I'll describe Cardio's activities to improve cardiovascular health and reduce disparities and identify ways you can get engaged with cardio, if not already. Next slide. So this is a map of the United States that I came across a few years ago and had not seen before, but it looks at heart attack and stroke rates across the different states in the United States. And really, Ohio, unfortunately, is in the top quartile of states for those heart attacks and stroke events. So we really have a real reason to sort of focus on cardiovascular health in Ohio in particular because of where we are across the US. Next slide. And just in terms of what we have in Ohio and our focus on Ohio, we really have some really modifiable risk factors. So we have 35% of Ohioans have high blood pressure, 21% are smokers, and 11% of Ohioans have diabetes. And so there's a real opportunity to help control these conditions and prevent them as a way of reducing our cardiovascular risk. And disparities exist. We talked a little bit, I guess the video sort of focused a little bit on that as well, but we have higher rates of uncontrolled high blood pressure, uncontrolled diabetes, and cardiovascular disease events among Black and Hispanic populations compared with whites in Ohio. We have greater hypertension and diabetes prevalence in the rural and urban areas compared with suburban settings. And smoking rates are higher in geographic areas with lower socioeconomic factors. Next slide. And this is just showing a map of Ohio where they've ranked the counties within Ohio. And so there's 88 counties in Ohio. And the Robert Wood Johnson Foundation does these county health rankings looking at length of life and quality of life. And just what you can see in this map is highlighting some of what I said in the last slide, that the urban and rural settings tend to have worse health outcomes, and that's also for cardiovascular health outcomes. And you can see that Cuyahoga County is also one of those areas where we need to really focus and that we have some work to do. Next slide. And I'm not trying to test your visions. I know that this text is really small and I will read through this, but this is a slide that came out of an article, and Dr. Joshua Joseph, who is at Ohio State and part of our Cardio Collaborative, worked on this article. But if we're going to talk about disparities, it is important to recognize the historical discrimination and racism that led to some of these disparities that exist today. And so that is really what this slide sort of outlines, and it's just examples. But on the left, there's been medical and scientific contributors to this, such as the closure of medical schools that were training Black physicians in the 1910s. Many of you are familiar with experimentation that happened on vulnerable groups without their consent. And those kinds of contributions have led to decreased trust in the medical establishment, has led to healthcare provider bias toward minority patients. And some of these have led to language and communication barriers. And on the right-hand side of this slide are looking at social conditions and policies. And I know Better Health has talked about this at other times and at other collaboratives, but the issue of redlining and predatory lending that led to racial residential segregation and housing insecurity, certainly the inadequate investment to maintain public works and school systems in minority neighborhoods, and discrimination in access to high quality jobs with adequate health insurance are some contributors that have led to structural and institutional racism. And all of those factors have really led to these issues around healthcare context and physical context that were just mentioned, sort of decreased access to healthy food, decreased neighborhood stability and cleanliness, decreased affordable housing, as well as poor access to care, decreased quality of care, less shared decision-making and patient-provider relationships, and low health literacy. And so all of those things combined have led to increased stress and other mechanisms that have led to increased blood pressure, obesity, cholesterol, and elevated blood sugar, which led to disparities in these cardiovascular health outcomes. So I know Donald mentioned, well, this is sort of an overwhelming slide. How do we all address not just this slide, but the prior slides, all of that to really improve outcomes and eliminate disparities. So in the next slide, and I do think that collaboratives can improve cardiovascular health and reduce disparities. I'll show some examples of that. Regional and statewide efforts and quality improvement activities are often fragmented. Just think about your own organization or health system or even community setting and how so many different activities are happening. And we often don't even know about those activities, which isn't necessarily a bad thing. But if you can imagine a bunch of people, as I have in this figure here or this photo, rowing, and if everybody's rowing, even if they're rowing in the same stream and trying to go the same direction, if everybody's sort of rowing a little bit off kilter, you're just not going to have the same impact that if I know about what you're doing and you know about what I'm doing. How can we really align those activities and partner together so when we row together, like these rowers are doing, we can have that really efficient rowing technique and really have a greater impact together. So I do think coordinated collaboratives can have a really strong impact on cardiovascular outcomes as we think about aligning together. Next slide. And many of you have seen this before, but Better Health Partnership in 2014 and 15 took on work to try and improve blood pressure control across our region. I was a part of that along with many others on the call today. And really looking at working with primary care clinics that had worse blood pressure control and how we could improve that together. And working together, we were really able to improve blood pressure control from around 66% of patients being under good control to 75% being under good control. If you look by insurance, we almost eliminated the gap and disparity in blood pressure control between uninsured Medicaid and Medicare and commercial insured. By race ethnicity, we almost completely eliminated the disparity between Hispanic and white populations in blood pressure control. And while we reduced the disparity between African American and white, we did not eliminate that. So that's an opportunity for continued improvement and how do we partner and really improve these outcomes. Next slide. And then in 2017, the Ohio Department of Medicaid funded Case Western Reserve University to really develop a statewide cardiovascular health collaborative focused on, and our mission was really to improve cardiovascular and now diabetes health outcomes and eliminate disparities in Ohio's Medicaid population. Really linked together all 7 medical schools across the state, but of course partnering with others beyond the medical schools. And we identify, produce, and disseminate evidence-based cardiovascular and diabetes best practices to primary care teams. And we use our monthly newsletters, our online website with lots of resources, our podcasts that are now available monthly, and some case-based learning training models where we have primary care teams join virtually to discuss cases to try and improve health. We did have annual statewide conferences, which have been on hold for a bit, and then virtual webinars. Next slide. And this is just showing the leadership across the different universities that have been, excuse me, partnering together to work on this collaborative. Next slide. And this are our 6 amazing team and team leadership to really produce the content and the work. Under team best practices, we probably have about 50 people from across the state that work to produce the content and all of the work that we have. So thanks to all of those teams. Next slide. And also Better Health Partnership has been a part of our collaborative as well. So another great reason to have us on today. This is our website, which is looking at where we have our best practices. Next slide. And we have I won't spend a lot of time on the slide, but just we have about 58 different resources on our website as fact sheets in a number of different areas, and you can see those here. We have videos of our echo didactics, which are our sort of 10 to 15-minute lectures on different topics around cardiovascular health. We have our 17 podcasts and capsules and then currents. And I'm going to just briefly highlight some examples of each of these categories, just a few, because you can go to our website and explore more. Next slide. So this is just one example. Our social determinants of health working group worked on developing a website document around what are available screening tools that primary care teams could use to identify social needs. And so this just describes some of those different screening tools so folks can decide what to use and how to use them. Next slide. Coming soon, we have a document on the hub pathways models across the state. Donald, I think, mentioned that earlier. Better Health has been a part of that. And this is showing the spread of those across the state, but that you can identify a patient with health-related social needs and refer them to a community health worker or to the hub pathway, who will assign a community health worker to work to try and address those concerns. Next slide. This is a structure of our echo clinic, but we basically have a 10-minute sort of topic presentation. And then we have 2 cases that are presented from the primary care teams. And different from a typical sort of learning scenario where we focus on solely medical treatment, we focus on medical treatment here, but we also talk about how do we engage patients in care and how do we address social determinants of health and mental health. So it's a bit broader than just sort of a medical, medication treatment and lifestyle treatment. Next slide. This is an example of our capsules, which we push out monthly. Again, the type is very tiny here. I don't expect you to read this, but this is around home blood pressure monitoring and practical instructions for patients. It's one of our most downloaded capsules. Really useful for patients that are having transportation issues, but we obviously want to do home blood pressure monitoring for a lot of other reasons as well. And we have lots of ways to implement this on our website that are really useful and practical for primary care clinics. Next slide. We started a Currents, which is just a monthly blurb on a particular article that has come out that might be useful to primary care clinics. So this is one that was on community health workers and telehealth and improving blood sugar levels in patients with diabetes, so that people could see what's out there and what they might want to emulate. Next slide. And this is looking at our podcasts. We have now 17 of these, but I'll just highlight a couple. One is the Addressing the Quadruple Aim in Healthcare, which Dr. Peter Pronovost from UH, actually University Hospitals, recorded with us, which has got a lot of listeners and actually has more than that now. We have a Disparities in Cardiovascular Disease and Diabetes Implications for Practice that Dr. Joshua Joseph in Ohio State worked on, and then a Hypertension Management in the Era of Telehealth, and lots more. So we encourage you to go. These are fun to listen to while you're driving, if you're driving to work. So it's a good opportunity to listen to these. Next slide. This is just showing our spread across Ohio for people that have gone to our website and used it. So we are getting a lot of use across the state. We're in a little bit of competition between Cleveland and Columbus for the most users, as you can see here. But we're really excited with the reach that we have, and we continue to work on that. Next slide. And I wanted to also mention, so Ohio Department of Medicaid also funded us to work on a hypertension and now a diabetes quality improvement project with high volume Medicaid practices across the state. And we improved blood pressure control in those practices by 14%, which is fantastic. But you can see still opportunity for greater improvement. Next slide. So this is my summary slide, and then I'm actually going to still have more slides, so it's a little bit of a trick slide, but my other slides will be around ways you can get engaged. This is just sharing that the previous slides, I think, have shown that cardio has grown over the last 4 years since we started, has successfully engaged with a number of wonderful stakeholders. We use multiple modalities to reach people, which has seemed to work really well. We do know that improving hypertension control and sustaining improvements is possible in diverse clinic settings, including those serving high proportions of disadvantaged populations, and that quality improvement coaching or practice facilitation in the context of a collaborative, both regional, like Better Health Partnership, or across the state with cardio, can have a strong impact. Next slide. So just some ways to get engaged. Next slide. We do have an upcoming webinar on the management of type 2 diabetes in the adolescent and young adult. And I want to highlight this because we have two wonderful speakers from university hospitals, Dr. Rose Gubitosi-Klug and Dr. Erica Lundgren, who will be presenting. And this is just such a critical area to improve care, as well as engaging families in improving adolescent and young adult type 2 diabetes. It's free CME and you can register on our website. Next slide. We have some other upcoming webinars. In February, we'll be talking about the use of race in medical guidelines and how, what's the emerging practices around that and how do we implement those. In spring, we'll be talking about LGBTQ+ populations and cardiovascular health for that webinar, and we'll have more details as we flesh those out. Next slide. This is our upcoming, we call it our spring tele-echo clinic, although it really does start in winter in January 27th to April 14th. It's Thursdays from 8 to 9. Its focus will be around weight management and behavior change. There's free CME for this. And this is primary care teams that can join and discuss cases. And again, as I mentioned earlier, it's not just medical and lifestyle treatment for weight management, but also focused around social determinants of health and how to engage patients in care. And Dr. Gautam Rao from University Hospitals leads this particular ECHO series. So hope that you're able to join us for some of that. Next slide. And last, I think this is my last slide on ways to engage, is we do have a monthly newsletter and encourage you to sign up for it if you have interest. This is just, usually we have our monthly capsule, monthly podcast, monthly current that I just mentioned that goes out in the newsletter. But we also had our top 5 downloads that we sent out recently. The 5 pearls for motivational interviewing has been one of our highest downloaded topics. So we mentioned that. And the other things we send out sometimes in our monthly newsletter relate to some policy issues. So we had, for instance, I just want everybody to know this, that all the Medicaid managed care plans now cover diabetes self-management education, and that's fairly new in the last few months, and relates to a lot of work that we did talking about how we can enhance diabetes outcomes with Medicaid. So really excited. We mentioned that in one of our newsletters, but I want to get that out as well. And then in January, we anticipate that continuous glucose monitoring will be available without prior authorization. It's currently available for Medicaid fee-for-service. So any of these policy kinds of things we try and also get out in our newsletter to folks. So, so sign up if you're interested. And then in the next slide, oh, there was one more. We just got funded by the Agency for Healthcare Research and Quality to do a Heart Healthy Ohio Quality Improvement Project. So we're working with 60 primary care practices across the state on blood pressure and smoking cessation and reducing disparities in those as well. So if you have if you're a primary care practice and you have interest in participating, we actually do still have a few slots open for our April cohort, which we're hoping to finalize in the next week or two. But if you have interest, contact Kathy Sullivan at this email, or you can reach out, I'm sure, to Carol and she'd get the word to me. Next slide. So I will end with this quote, because I think we've talked again about a lot of things that take a lot of people working together, but never doubt that a small group of thoughtful, committed people can change the world. Indeed, it's the only thing that ever has. So I will let you sort of think about that as we hear all the other discussions today. And on the next slide is really just an acknowledgement of all of the of all the folks that really contributed to this work, including Better Health and Ohio Department of Medicaid. And of course, I need to mention that the views I expressed here are solely my own. and do not represent the views of the state of Ohio, any federal Medicaid programs, the CDC, the U.S. Department of Health and Human Services, or any other funder. So I know time is tight, and Donald will probably be trying to move us on to the next presentation. If you have questions, I'm happy to answer them in the chat and respond that way. And I am also happy to connect with anyone offline. Thank you, Donald.
Thank you, Shari. Thanks so much for that presentation and for the great work and collaboration that you're doing. We do have a couple of minutes, and there are a couple of things that came up in the chat. I would invite, if people have questions for Dr. Bolen, go ahead and put them in the chat. We'll try to address as many as we can. There was one comment about being surprised that cardio does not address obesity as a disease and a root cause for heart disease and diabetes. You did show the slide from the project led by Dr. Rao. Would you care to say any more about that?
Yeah, it's absolutely. I think I mentioned it it was probably in one of those, but yeah, and also the case series focused on weight management. But yes, absolutely. Obesity is clearly an upstream factor. We've had many discussions, probably should be careful about what I say in a large forum about trying to get better coverage for diabetes prevention program, for instance. But yes, there's clearly a lot of work that needs to be done. And we focus on evidence-based strategies around obesity on our website. And we also have our case series on it, but certainly moving policy levers around that is important as well.
And for those who are not in clinical practice in the group, I would point out that there really is a revolution in treatment of diabetes, weight, and heart disease in terms of new medications that are on the market, the SGLT2 inhibitors and the GLP-1 agonists. So one question I have is there a way to address inequity in pharmaceutical availability?
So that's a great comment. Cardio is a little bit of a challenge because the funding stream is through CMS. We're not allowed to do policy work as part of the funding. Having said that, I sort of mentioned some of the policy issues, and certainly we all work within health systems that can work on policy. So it clearly does come up. So I was on the National Clinical Care Commission where we worked, we just submitted something to Congress that they have to act on within 90 days. This is sort of separate from cardio, but looking at ways we can deal with the cost issue in medical expenditures. But it's a very important policy issue beyond even cardiovascular health, but clearly an important one. I don't know if I fully answered that question.
Well, it's helpful to know that that's on the radar. Another question from the chat: are local health departments represented in the Cardio Collaborative?
Yes, so we do engage with Ohio Department of Health. I think the way that local groups engage with their local health departments is different. Something we've encouraged a lot of engagement from our partner institutions with their local departments of health, and have had conversations with many of them. So it really just varies across the state. The focus of the funding stream is focused on through CMS to Medicaid providers, and so that is part of the budgetary restrictions, but that doesn't mean that cardio can't and doesn't partner with lots of other organizations to do work. So that you'll see that's sort of the reason there's a focus around the primary care teams is related to the budgetary restrictions, but many of us partner with our local departments of health, and we continue to try and do that to enhance the work that's happening.
Great. And one final question: why are there not more African American providers involved, or are there?
Yeah, I mean, I probably just showed the leadership and the teams, and I think there's some representation, but it's limited there. I mean, across the 50, I mean, I'd have to look at our breakdown. We do have African American providers and other providers across the team best practices, and I mentioned that has sort of 50 providers across the state. But I think that is certainly open to discussions, Dr. Murphy, on ways to enhance that. So I think always looking for great ways to do that and get out there more.
Terrific. Well, thank you so much for your presentation and for the work that you're doing. And I appreciate your offer. If there are further questions, to answer them through the chat. If you're able to, we'll get as much as we can on the recording. So thank you very much, Dr. Bolen.